Crest syndrome, also known as limited cutaneous systemic sclerosis, is an autoimmune condition, and its name is an acronym that stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. Calcinosis is the deposition of calcium in the skin. Raynaud's is a spasm of the arteries in the fingers. Esophageal dysmotility refers to difficulty swallowing. Sclerodactyly is tightening of the skin over the fingers. And telangiectasias are small dilated blood vessels on the skin surface. So normally when there's an infection in the body, macrophages will eat some of the invading organisms and break them down. In addition to destroying the pathogen, they also present a fragment of that pathogen, called an antigen, to naive T cells. When the naive T cells bind to this presented antigen, they mature into helper T cells, also called CD4 positive T cells, and they go on to help and recruit more immune cells. The helper T cells release cytokines, which increase the activity of macrophages and attract nearby neutrophils. They also release cytokines, like TGF-beta, that tells fibroblasts to repair damaged tissue after the infection by laying down collagen. The cause of Crest syndrome isn't known exactly, but individuals in the first 2 years of the disease have a higher than normal number of T helper cells in the skin on their hands and face, particularly near small blood vessels. The T helper cells release cytokines to attract other immune cells, like macrophages and neutrophils, which cause a lot of inflammation in the skin. There is so much inflammation that the tissue dies in a process called necrosis. When the cells die, calcium in the cytosol binds to fragments of cell membrane and builds up in the skin, which is called calcinosis. It's not clear why it happens, but individuals with Crest often experience Raynaud's phenomenon, which is an episodic, dramatic vasoconstriction of arterial blood vessels in the hands. It's not quite clear what is going on, but in Crest syndrome there is often difficulty in swallowing food, which we call esophageal dysmotility. The inflammation in the skin also damages blood vessels, which eventually results in poor blood flow, called ischemia. This causes more damage to the skin, particularly in the hands and fingers. The severe ischemia and tight skin in the fingers can cause ischemic ulcers, and even finger loss if left untreated. The body tries to repair the damage by activating fibroblasts, which lay down bundles of collagen. The T helper cells also release more cytokines, like TGF-beta, which keeps these fibroblasts switched on. This collagen builds up in the skin of the fingers and hands, causing sclerodactyly, with sclero referring to thickening and dactyly referring to the fingers. The vascular damage also causes telangiectasias, which are tiny dilated capillaries, usually on the skin of the hands. People with Crest syndrome might report hard bumps on their hands or fingers if they have calcinosis. They might also say that their fingers change color or turn white from time to time, especially if they're cold. Raynaud's phenomenon is typically the first thing individuals with Crest syndrome notice. The sensation of food getting stuck in the esophagus, or difficulty swallowing, is a symptom of esophageal dysmotility. They may have to drink water with every bite to make sure the food goes down properly. Early on in the disease, the skin of the fingers might be swollen and painful, but later on will be thicker and tighter than usual. They might also notice red spots or dots on their hands and sometimes on their face or neck. Crest is diagnosed by thorough history and physical examination. There is an association between Crest syndrome and an autoantibody called anti-centromere antibody. A serum blood test for anti-centromere antibody will confirm the diagnosis of Crest syndrome in about 60% of people. There's no cure for Crest syndrome, but it can be managed with steroids initially and with stronger immunosuppressants like cyclosporin if the disease progresses. Alright, as a quick recap, Crest syndrome stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. It is a less severe form of systemic sclerosis and is caused by T helper cell activation, which causes damage to skin and blood vessels and results in fibrosis. Anti-centromere antibody can be used to confirm diagnosis, and it is treated with steroids and sometimes with immunosuppressants.
Raynaud phenomenon is a phenomenon where there's constriction of arteries near the skin that make a body part, often the fingers, turn white, then blue, and then red, in response to a trigger like cold weather. The phenomenon is named after Auguste Gabriel Maurice Raynaud, a French physician who first described it. To clear up some potentially confusing terminology, it's called Raynaud disease or primary Raynaud phenomenon when the condition happens alone, and is not associated with any other disease. And it's called Raynaud syndrome or secondary Raynaud phenomenon when it's associated with diseases like systemic lupus erythematosus or scleroderma. Normally, blood flows from large arteries into medium-sized or muscular arteries, and then into small arterioles which carry the blood to capillary beds. All arterial vessels have 3 layers. From inside moving out, there's the endothelium, then the media layer which contains smooth muscle, and finally the adventitia layer, which has loose connective tissue and nerves. Some nerve fibers in the skin function as thermoreceptors, which sense changes in temperature. When stimulated, they cause the nerve to fire, sending signals up through the spinal cord to the hypothalamus, which is at the base of the brain. The hypothalamus serves as the body's thermostat because it coordinates the brain's response to temperature changes. The hypothalamus is what triggers the thought, hey, it's pretty cold here. Maybe I should find a friendly llama to snuggle with for warmth. The hypothalamus also coordinates changes in the sympathetic and parasympathetic nervous system. For example, normally there's a lot of heat energy in the blood that gets lost to the environment. When the sympathetic nervous system gets stimulated, it causes contraction of smooth muscle that wraps around arterioles, causing vasoconstriction and a reduction of blood flow to the skin. That shunts blood away from the skin and towards the body's core, or organs where less heat energy is lost. In Raynaud phenomenon, triggers like the cold or even emotional stress cause sympathetic nerves in the walls of the arterioles to get overstimulated, and that makes the arterioles vasoconstrict. If the vasoconstriction happens briefly or intermittently, it's called a vasospasm. When the arterioles vasoconstrict, it dramatically decreases blood flow to downstream tissue. For example, if there's a vasospasm in the arterioles in the fingers, it causes the fingers to turn white, reflecting ischemia, then blue, reflecting hypoxia, which is the low oxygen state that happens after prolonged ischemia. Finally, once the vasospasm ends, oxygenated blood rushes into the tissue, causing what's called reactive hyperemia, which makes the fingers look red. This blood rush is thought to be the cause of swelling, tingling, and pain that some people experience at this point in the episode. Now, there are a few important differences between primary and secondary Raynaud phenomenon. Primary Raynaud phenomenon usually affects the fingers and toes symmetrically, and the severity stays roughly constant over time. The arteries themselves typically remain undamaged, unless the episodes happen frequently over many years, in which case there might be some thickening of the arterial wall. The most common triggers are stress and cold temperatures, but other potential triggers include nicotine and caffeine, as well as medications that affect the sympathetic nervous system like pseudoephedrine. Primary Raynaud phenomenon is common among pregnant women, and is common among those who work in jobs that require lots of vibration, like using a jackhammer. In contrast, secondary Raynaud phenomenon usually affects fingers and toes asymmetrically, and there's progressive severity, because there's often underlying damage to the arteries. It's also often associated with connective tissue disorders like systemic lupus erythematosus and scleroderma, as well as vasculitides like Bergère disease and Takayasu arteritis. Symptoms of Raynaud's disease include color changes in the fingers and toes, as well as numbness, tingling, and pain once the blood returns. Sometimes it can affect the nose, ears, and lips, all of which are places that get cold in the snow. If the vasospasm gets severe enough, this lack of blood flow can cause tissue death. The diagnosis of Raynaud's disease is usually based on description of the episodes and exploring for a possible underlying condition. Occasionally, nail fold capillary microscopy is done to see whether finger capillaries are normal appearing, which would be consistent with primary Raynaud phenomenon, or if they're damaged, which would be consistent with secondary Raynaud phenomenon. Treatment includes avoiding triggers like cold temperatures, smoking, and caffeine, and occasionally using a medication like a calcium channel blocker to help with vasodilation of the arteries. In severe cases, surgery can be done to cut the sympathetic nerve fibers supplying the affected areas. Alright, as a quick recap. Raynaud phenomenon is vasospasm of arterial blood vessels that causes a body part, often the fingers, to change from white to blue and then to red once the vasoconstriction ends. It's most commonly triggered by cold exposure or emotional stress. It's called Raynaud disease or primary Raynaud phenomenon when it happens alone. And it's called Raynaud syndrome or secondary Raynaud phenomenon when it happens along with another disease process.
Hey, Evan here. Hope you enjoyed our video on Raynaud or Raynaud's phenomenon or disease or syndrome or whatever you want to call it. We hope you enjoyed the video anyway, and I want to make sure that I don't get anything close to it. So staying warm this winter. Hope you're staying warm too, and I hope you're having a good day, because for me, nothing ruins a good day more than being really, really cold. So I hope you don't have to deal with that unless you want to, and that's your idea of a good day. That's fine. If being cold's your idea of a good day, tell us about it in the comments, or tell us whatever in the comments, as long as it's not mean, because we don't tolerate being mean. Anyway, if you liked our video, if you like this video and you want videos similar to it, you can check out our Prime service on osmosis.org, where we have over 100 videos that you can't find on YouTube. Nowhere. You can check under the rug. They're not there. They're not in the corner. They're not in the closet. They're only on osmosis.org. Trust me. I've seen them. Anyway, I hope you enjoyed this video and you learned something from it. And we'll see you next time. Bye.
While doing your rounds, you see Rosa, a 35-year-old woman who has complained of puffy hands and feet for the past 4 months. On examination, the skin on the limbs and trunk is stiff and shiny, with decreased markings. Other important findings are sclerodactyly, digital ulceration, and Raynaud's phenomenon. Pulmonary function tests were performed as well, and they showed a pattern suggestive of restrictive lung disease. Then you see Haruki, a 65-year-old who says that he noticed skin changes recently, stating that the wrinkles on his face have disappeared. He's also said that his acid reflux got worse in the past 6 months. On examination, his hands show Raynaud's phenomenon and sclerodactyly. The skin on his face and the arms below the elbow were tight, shiny, smooth, with no wrinkles. Pulmonary function tests are normal. Blood tests were performed in both cases, showing increased serum levels of anti-scleroderma 70 and RNA polymerase III antibodies in Rosa, and increased anti-centromere antibodies in Haruki. Now, both seem to have scleroderma. Scleroderma refers to systemic sclerosis, a rare autoimmune disorder in which normal tissue is replaced by thick, dense collagen. It affects the skin, blood vessels, and internal organs. Now, there are 2 main types of scleroderma: diffuse cutaneous systemic scleroderma and limited cutaneous systemic scleroderma, which was formerly called CREST syndrome. The condition's pathology is not completely understood, but it is believed that some individuals have a genetic predisposition to scleroderma, which is triggered by external factors. These triggers include viral infection by cytomegalovirus and parvovirus B19, exposure to silica dust, organic solvents, vinyl chloride, and medications like cocaine, bleomycin, and pentazocine. Okay, for pathology, scleroderma usually starts with an injury to the endothelial cells that line the interior surface of small blood vessels, causing non-inflammatory vasculitis. These cells then start expressing adhesion molecules that T cells stick to. T cells then migrate outside of the blood vessels and into the surrounding tissue, where they start releasing cytokines, which attract other immune cells that further damage small blood vessels, and activate fibroblasts that produce and deposit collagen. In time, collagen builds up and forms a highly stable matrix that is responsible for the stiffness of the tissue. This buildup of excess connective tissue is called fibrosis. Finally, blood vessel damage and fibrosis reduce blood flow to the tissue and cause ischemic tissue damage. There is another type of immune cell that plays a role in scleroderma, which are B cells. What's causing them to activate is currently unknown, but we do know that activated B cells produce anti-nuclear antibodies, or ANA, that bind to the content of the nucleus, which leaks out of damaged or dead cells. Some ANAs are both highly specific to scleroderma, so they are very high yield. These include anti-scleroderma 70, which targets DNA topoisomerase 1, anti-RNA polymerase 3, and anti-centromere antibodies. For symptoms of scleroderma, both types affect women 3 times more often than men, especially women over 50 years of age. The 2 types can affect the same organs and cause similar symptoms, but the disease progression can differ. Let's start with diffuse cutaneous systemic scleroderma, where symptoms are usually rapidly progressive and it's associated with visceral involvement early in its evolution. Okay, so skin lesions start in the fingers and move up across the arm to the shoulders, neck, and face. At first, the affected skin is swollen and puffy. Later, when fibrosis develops, the skin becomes tight, stiff, shiny, smooth, but with no wrinkles, especially around the fingers and dorsum of the hands. When it happens on the fingers, it is called sclerodactyly, which can cause fingers to curl inward so that the hand becomes shaped like a claw. On the face, the mouth can become narrow, which is called microstomia, and the nose becomes beaked. Sometimes, calcium can deposit in the skin and subcutaneous tissue through an unknown mechanism, and this is called calcinosis cutis. Small vessel involvement can lead to Raynaud's phenomenon, where the distal parts of the fingers turn white when exposed to cold, due to vasospasm. Then the color changes to blue, and finally red as the blood vessels expand to get enough oxygen-rich blood to the fingers. In time, because vasospasm can cause ischemia, individuals might develop digital ulcerations. Scleroderma can cause telangiectasias as well, also known as spider veins, which are small, dilated blood vessels that can occur near the surface of the skin or mucous membranes. Another common site of damage is the joints, where symptoms are typically nonspecific and can include joint pain, stiffness, and restricted joint mobility. In the gastrointestinal tract, there can be esophageal dysmotility and incompetence of the lower esophageal sphincter due to atrophy and fibrous replacement of the esophageal muscularis. This can result in gastroesophageal reflux disease, or GERD, which is when the content of the stomach flows up to the esophagus and damages it. Due to stomach acid irritating the normal esophageal mucosa, Barrett's esophagus can develop, which is when the normal stratified squamous epithelium of the esophagus transforms into simple columnar epithelium with interspersed goblet cells, like the ones normally found in the small and large intestines. This is high yield because it can lead to esophageal adenocarcinoma. Chronic damage and fibrosis to the esophagus can cause stricture formation. The intestines can also be involved, which leads to malabsorption, and then to anemia due to iron deficiency. The next high-yield fact to remember is that lungs are commonly involved. Small blood vessels can be damaged and cause pulmonary arterial hypertension and pulmonary fibrosis, which can be seen as restricted inhalation and coughing. Lung damage can lead to hypertrophy of the heart's right ventricle and then heart failure. Finally, kidney involvement is very common, where the small arteries in the kidneys undergo concentric hypertrophy, resulting in ischemia over time. But sometimes, severe and rapid damage can occur during a scleroderma renal crisis. This is where the damaged blood vessels trigger thrombosis, causing blockage in capillaries. The end result is acute kidney injury and severe hypertension. Okay, in contrast, in limited cutaneous systemic scleroderma, or CREST syndrome, the progression is usually slower, so there's no sign of internal organ involvement in its initial stages. And even in the later stages, the damage to organs tends to be less severe. However, remember that pulmonary hypertension is quite common, but thankfully, renal and intestinal involvement are pretty rare. Remember that there are 5 key symptoms of CREST: calcinosis cutis, Raynaud's phenomenon, which is usually the first symptom, esophageal dysfunction, which is actually common in both types, sclerodactyly, and telangiectasia. For the skin manifestations, a high-yield concept is that in the limited type, it tends to be, limited to the face and the distal limbs, meaning below the elbow and knees, whereas in the diffuse type, it can affect the entire body. Diagnosis of scleroderma is based on its symptoms, but antibody tests can help confirm the diagnosis. A high-yield concept to remember is that diffuse scleroderma are associated with anti-scleroderma 70 and anti-RNA polymerase III antibodies. The limited type is more commonly associated with anti-centromere antibodies. Next, evaluating organ damage is also important. Pulmonary function tests can be used to look for restrictive lung disease. It's also important to look for signs of pulmonary artery hypertension. This can be done by electrocardiography, which shows right ventricular hypertrophy and right axis deviation, and by chest X-ray, which can show right ventricular enlargement, a prominent central pulmonary artery, or peripheral hypervascularity. If any of these tests are positive, right heart catheterization is required to confirm the diagnosis of pulmonary artery hypertension and to evaluate the severity. And of course, there are other tests, like upper endoscopy for gastrointestinal symptoms, complete blood count to detect anemia due to malabsorption, which can be used to look for other organ involvement in scleroderma. For treatment of this condition, immunosuppressants like glucocorticoids are used to slow down the disease. Other medication can be used to relieve symptoms: proton pump inhibitors for gastroesophageal reflux, calcium channel blockers for Raynaud's phenomenon, non-steroid anti-inflammatory medication for joint pain, ACE inhibitors for hypertension, and medication like oral anticoagulants like warfarin or vasodilators for pulmonary arterial hypertension. Now, extra attention needs to be paid to those with scleroderma renal crisis, since this is a really important complication. A crisis is usually managed with strict blood pressure monitoring. A sudden increase in blood pressure indicates a sclerodermal renal crisis, and ACE inhibitors like captopril may be needed to control blood pressure. Calcium channel blockers like amlodipine, diuretics like furosemide, and alpha blockers such as doxazosin should be used as additional therapy if blood pressure control remains suboptimal. Alright, as a quick recap, scleroderma is a rare autoimmune disorder in which normal tissue is replaced with thick, dense connective tissue. It affects the skin, blood vessels, and internal organs. There are 2 main types: diffuse cutaneous systemic scleroderma, which affects a larger area of the skin, progresses quicker, involves internal organs earlier with more severe symptoms, and limited cutaneous systemic scleroderma, formerly called CREST syndrome, which usually has only 5 of the main symptoms, affects a smaller area of the skin, progresses slower, and involves internal organs much later. The cause is not known, but a genetic predisposition is thought to be involved. It is more often found in women over 50 years old, and some of its symptoms include tight, stiff, shiny, and smooth skin with no wrinkles, calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, telangiectasias, microstomia, gastroesophageal reflux, pulmonary fibrosis, and scleroderma renal crisis. It is diagnosed based on a suggestive clinical picture, anti-nuclear antibodies, and additional findings related to scleroderma complications. The treatment includes immunosuppressants and other medications to relieve symptoms. Okay, now back to our cases. Rosa came in with the complaint that her hands and feet were puffy. An examination revealed the skin on her limbs and trunk to be stiff and shiny. Other important findings are sclerodactyly, digital ulceration, and Raynaud's phenomenon. These symptoms all suggest scleroderma. Since entire limbs are affected, this is more suggestive of the diffuse type because the limited type tends to affect only the distal limbs. Pulmonary function tests showed a pattern suggestive of restrictive lung disease, which also makes us think that this is diffuse cutaneous systemic scleroderma. This was confirmed when antibodies anti-scleroderma 70 and ARNA polymerase III were found. Haruki also presents with the symptoms of scleroderma, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, and telangiectasia. A clue that he might have limited cutaneous systemic scleroderma is that his skin lesions were limited to the face and distal limbs. And because pulmonary function tests are normal and blood tests showed anti-centromere antibodies, we can confirm this diagnosis.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today.
Scleroderma refers to systemic sclerosis, a rare autoimmune disorder in which normal tissue is replaced with thick, dense connective tissue. It affects the skin, blood vessels, and internal organs. Now, there are two main types of scleroderma: limited cutaneous systemic scleroderma, better known as CREST syndrome, and diffuse cutaneous systemic scleroderma. The word scleroderma comes from the Greek words sclero, meaning hard, and derma, meaning skin, which points to the hard skin as its most visible feature. So normally, when there's an infection in the body, macrophages will eat some of the invading organisms and break them down. In addition to destroying the pathogen, they also present a fragment of the pathogen, called an antigen, to naive T cells. When the naive T cells bind to this presented antigen, they mature into T helper cells, also called CD4 positive T cells. And they go on to help and recruit more immune cells. The T helper cells release cytokines, which increase the activity of macrophages and attract nearby neutrophils. Macrophages also release cytokines, like TGF-beta, that tell fibroblasts to repair damaged tissue after the infection by laying down collagen. Scleroderma affects women 3 times more often than men. The exact pathology of scleroderma is not completely understood, but generally it's thought that some individuals have a genetic predisposition to scleroderma, which is triggered by external triggers. Some known triggers include viral infection by cytomegalovirus and parvovirus B19, exposure to silica dust, organic solvents and vinyl chloride, and drugs and medications like cocaine, bleomycin, and pentazocine. It's thought that there's initially an injury to endothelial cells lining the small arteries. These cells then start expressing adhesion molecules that attach to T cells floating by. T cells attach and then migrate outside of the blood vessel into the surrounding tissue and start releasing cytokines like TGF-beta, which causes inflammation and further damages small blood vessels. Cytokines also activate fibroblasts that produce and deposit collagen, which builds up and forms a highly stable matrix that is responsible for the stiffness of the tissue. This buildup of excessive connective tissue is called fibrosis. Finally, blood vessel damage and fibrosis reduce blood flow to the tissue and cause ischemic tissue damage. There's another type of immune cell that plays a role in scleroderma, and that's B cells. It's not known how they are activated or if they cause any damage, but activated B cells do produce antinuclear antibodies, or ANA, which bind to the content of the cell nucleus. Some ANAs are highly specific to scleroderma and can help make the diagnosis. These include anti-SCL70, which targets DNA topoisomerase 1, anti-RNA polymerase III antibodies called ARA, and anti-centromere antibodies called ACA. Scleroderma can affect any organ, but it usually involves the skin, gastrointestinal tract, lungs, heart, and kidneys. Skin lesions start in the fingers and move up across the arm to the shoulders, neck, and face. At first, the affected skin is swollen and doughy. Later, when fibrosis develops, the skin becomes tight, shiny, smooth, and stiff. When it happens on the fingers, it's called sclerodactyly, which can cause ulcerations and can also cause the fingers to curl inward so that the hand becomes shaped like a claw. On the face, the mouth can become narrow, called microstomia, and the nose becomes beaked. Due to the damage in the small vessels, there is Raynaud phenomenon. in which fingers turn white when exposed to cold. Then the color changes to blue, and finally red as the blood vessels expand to get enough oxygen-rich blood to the fingers. In the gastrointestinal tract, there can be esophageal dysfunction and gastroesophageal reflux, which is when the content of the stomach flows up to the esophagus and damages it. And also, the intestine can be damaged, which leads to malabsorption. Blood vessels of the lungs can be damaged and cause pulmonary arterial hypertension and pulmonary fibrosis, which can be seen as coughing and difficulty breathing. Lung damage can lead to hypertrophy of the heart's right ventricle and heart failure. Finally, kidney damage can cause hypertension and kidney failure. In limited scleroderma, or crest syndrome, the first symptom in most individuals is Raynaud phenomenon. The skin of the fingers and face can be affected, while internal organ damage comes much later in the disease. The syndrome itself is named after its most common symptoms: calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. In the diffuse scleroderma, skin of the arms, legs, trunk, and face are affected, and organ damage occurs earlier. Diagnosis of scleroderma is based on its symptoms, the presence of specific antibodies like anti-SCL70, ARA, and ACA, and sometimes additional tests like blood pressure, upper endoscopy for gastrointestinal symptoms, complete blood count to detect anemia due to malabsorption, and pulmonary function tests to assess for lung damage. In terms of treatment, immunosuppressants are used to slow down the disease. Other medication can be used to relieve the symptoms: proton pump inhibitors for gastroesophageal reflux, calcium channel blockers for Raynaud phenomenon, non-steroid anti-inflammatory medication for the pain, and ACE inhibitors for hypertension. All right, as a quick recap, scleroderma is a rare autoimmune disorder in which normal tissue is replaced with thick, dense connective tissue. It affects the skin, blood vessels, and internal organs. There are two main types: diffuse, which affects a larger area of the skin, progresses quicker, and involves internal organs earlier, and limited, or crest syndrome, which affects a smaller area of the skin, progresses slower, and involves internal organs much later. The precise cause is not known, but the autoimmune process leads to excessive collagen production in individuals with a genetic predisposition. Scleroderma most commonly affects the skin, gastrointestinal tract, lungs, heart, and kidneys. It's diagnosed based on the symptoms, anti-nuclear antibody finding, and additional findings related to the disease, like hypertension and gastroesophageal reflux. The treatment includes immunosuppressants and medications to relieve the symptoms.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
On your rounds, you see a 55-year-old female named Patricia who presents with fatigue, dry skin, and red eyes. She mentions that she's had a recurrent sensation of sand in her eyes and dry mouth every day for the past 3 months. She also mentioned that when it's cold outside, the tips of her fingers turn white and hurt. On examination, there are signs of tooth decay and purpura on both lower extremities. Sialometry was performed, which detected salivary hypofunction. Okay, so Patricia's clinical picture is suggestive of Sjogren's syndrome. Now, Sjogren's syndrome is an autoimmune disorder that mostly affects middle-aged females. The high-yield concept here is that the immune system attacks various exocrine glands, especially salivary and lacrimal glands. If Sjogren's syndrome is primary or occurs alone, it's called Sika syndrome. Alternatively, it can be secondary when it is accompanied by other autoimmune diseases like lupus, rheumatoid arthritis, and scleroderma. Now, the exact cause of Sjogren's syndrome is unknown, but both genetic and environmental factors are involved. In Sjogren's syndrome, Some helper T cells perceive nuclear components that leak out of dead or damaged cells in the body as antigens. These T cells become active and proliferate, and then activate B cells, which start producing anti-nuclear antibodies, or ANAs, against the nuclear antigens. A high-yield fact to remember is that the two types of ANA formed in Sjogren's syndrome are anti-SSA-Rho and anti-SSB-La antibodies, which are formed against ribonuclear proteins SSA and SSB. Next, both T cells and antibodies enter the circulation and reach the exocrine glands, where activated T cells secrete cytokines to recruit even more immune cells. This results in lymphocytic infiltration of the exocrine glands, which ends up damaging the exocrine gland tissue. Eventually, the secreted cytokines also activate fibroblasts, which produce fibrous tissue that replaces the damaged tissue. The end result is a loss of secretory cells in the glands. The resulting symptoms of Sjogren's syndrome can be divided into two main categories. First up are glandular manifestations, where involvement of the eyes or salivary glands occurs first and sometimes exclusively. Lacrimal gland involvement results in decreased tear secretion, which leads to dryness of the eyes, blurry vision, irritation, which is described as a sensation of sand in your eyes, redness, and ultimately to keratoconjunctivitis, which is inflammation and ulceration of the cornea and conjunctiva. Salivary gland involvement usually leads to diffuse fibrosis and painless enlargement of the gland. So remember that if you see nodules, think neoplasm instead. The diffuse damage to the glands leads to xerostomia, or dry mouth, due to decreased saliva secretion. The lack of saliva causes mucosal atrophy and fissuring of the tongue. It can also lead to decreased sensation of taste, problem swallowing, and tooth decay. If it involves the parotid glands, fibrosis can lead to bilateral parotid enlargement, which can compress on the nearby nerves, causing pain. In the nose and airways, Sjogren's syndrome causes dryness that leads to ulceration and bleeding. And if this affects the larynx, it can lead to difficulty speaking. And finally, some people can experience dryness of the skin and vagina, which might cause dyspareunia or painful intercourse. Extraglandular manifestations occur when the syndrome affects organs beyond the exocrine glands, especially if it overlaps with another autoimmune disorder. Systemic symptoms can include fever, fatigue, myalgia or muscle pain, unintentional weight loss, and lymphadenopathy. Joint involvement is typically manifested as arthralgia, or joint pain, with or without inflammatory arthritis, and it actually occurs in 50% of people with Sjogren's syndrome. There can also be vascular conditions like purpura, which occurs due to bleeding within the skin secondary to vasculitis, or Raynaud's phenomenon, which is where arterial spasms reduce blood flow to the fingers for a few minutes at a time. The fingers turn white and then blue, often with numbness or pain. And then as blood flow returns, the fingers turn red. Lung problems include a chronic cough, as well as interstitial lung disease, which results in a restrictive pattern on pulmonary function tests. Renal involvement can cause interstitial nephritis and defects in tubular function, causing creatinine levels to rise. The condition can be associated with autoimmune thyroiditis, hypergammaglobulinemia, monoclonal gammopathies, and cryoglobulinemia. Finally, a really high-yield concept to know is that over time, Sjogren's syndrome can lead to lymphomas. One type is a non-Hodgkin lymphoma called mucosa-associated lymphoid tissue, or MALT lymphoma, which is typically associated with chronic inflammation. MALT lymphoma can present as nodular parotid enlargement instead of the diffuse enlargement normally seen in Sjogren's syndrome. So keep that in mind. Since virtually any organ or gland can be affected, diagnosis is based on symptoms relating to salivary gland, mouth, and eye involvement. These symptoms must persist for more than 3 months and must occur daily. Next, tests that identify salivary gland hypofunction should be done. One option would be quantitative salivary gland scintigraphy, also called technetium excretion radionuclide scanning, which shows how the major salivary glands are functioning based on their uptake of a radionuclide. There's also whole sialometry, which measures the rate of saliva production by measuring the amount of saliva someone can produce over a time frame. In addition, imaging like ultrasound or MRI can be used to identify enlargement of the salivary glands. Finally, labial salivary gland biopsy can be done as a confirmatory test, and it typically shows focal lymphocytic sialadenitis. That's where there's a focal collection of cells, especially CD4 positive T cells, plasma cells, and macrophages, and thickening of the inner duct wall. Eye involvement is tested by the Schirmer test, which measures reflex tear production, and it typically shows aqueous tear deficiency. Another test is ocular surface staining. That's where a dye like fluorescein is used to stain areas of damaged tissue, which is then observed under a slit lamp to look for signs of keratoconjunctivitis. And the final test is the tear breakup time, which assesses how fast the film of tears that normally spreads over the eyes while blinking takes to dry. In Sjogren's syndrome, this occurs faster than normal. Finally, blood tests are also needed for diagnosis. In Sjogren's syndrome, there's often a low white blood cell count, elevated globulins, and an elevated ESR, while CRP might be normal or slightly elevated. When it comes to autoantibodies, primary Sjogren's syndrome is associated with anti-SSA-Rho and anti-SSB-La, while secondary disease can also present other antibodies like ANA and rheumatoid factor, depending on the associated autoimmune condition. Other tests might be necessary, especially pulmonary function test, to assess lung function, since the lung involvement is highly common. Okay, for treatment. Individuals with mild Sjogren's syndrome, without other organ involvement, can be treated with secretagogues. This includes muscarinic agonists such as pilocarpine and cevimeline that can increase the production of saliva and tears. Artificial tears for eye dryness can also help relieve symptoms. Individuals with moderate to severe Sjogren's syndrome, with major salivary gland enlargement or involvement of other organs, generally require systemic medical therapy. Major salivary glandular enlargement due to inflammation can be treated with glucocorticoids. Individuals with involvement of other organs are started on disease-modifying anti-rheumatic drugs, or DMARDs. Most individuals are started on non-biological DMARDs like hydroxychloroquine and methotrexate. By contrast, severe disease gets biological DMARDs, all of which suppress some part of the immune system, such as the alkylating agent cyclophosphamide and the anti-CD20 antibody rituximab, which targets B cells. Alright, as a quick recap, Sjogren's syndrome causes the autoimmune destruction of the exocrine glands, most commonly the salivary and lacrimal glands. It can be primary when it's called Sika syndrome, or it can be secondary when it occurs alongside other autoimmune diseases. The most common glandular symptoms include dryness and irritation of the eyes, blurry vision, redness, keratoconjunctivitis, xerostomia, difficulty in tasting and swallowing, tooth decay, bilateral parotid enlargement, and dryness of the vagina. Extraglandular manifestations can include fever, fatigue, myalgia, purpura, Raynaud's phenomenon, interstitial lung disease, joint pain, interstitial nephritis, and malt lymphoma. Diagnosis is based on clinical findings and on a series of tests like quantitative salivary gland scintigraphy and whole sialometry, which can detect salivary hypofunction, labial salivary gland biopsy, which typically shows focal lymphocytic sialadenitis, the Schirmer test, which can show aqueous tear deficiency, ocular surface staining, showing signs of keratoconjunctivitis, and the tear breakup time. Blood tests might also reveal elevated levels of autoantibodies. Primary Sjogren's syndrome is associated with anti-SSA-Rho and anti-SSB-La, while secondary disease can also present with other antibodies, like ANA and rheumatoid factor. Pulmonary function tests should also be performed to assess lung function. Individuals with mild Sjogren's syndrome can be treated with secretagogues such as pilocarpine and cevimeline. Moderate to severe Sjogren's syndrome requires disease-modifying anti-rheumatic drugs, or DMARDs. Now back to our case. Patricia came in with symptoms of fatigue, dry skin, dry mouth, red eyes, and Raynaud's phenomenon. These symptoms are highly suggestive of Sjogren's syndrome, especially since they occurred for more than 3 months. Examination revealed signs of tooth decay and purpura on both lower extremities, which also fits the diagnosis. Sialometry detected salivary hypofunction, and together with her symptoms, should be enough to diagnose Sjogren's syndrome. The next step would be blood work to look for anti-SSA-Rho and anti-SSB-La antibodies, and to check for signs of corneal ulceration, as well as involvement of the lungs and other organs.
Sjogren's syndrome, named after Dr. Henrik Sjogren, who first identified it, is a common autoimmune disorder, typically happening in women. In Sjogren's syndrome, the body's immune cells go rogue and start attacking various exocrine glands, which are glands that pour their secretions into a duct, most commonly the salivary glands and the lacrimal or tear glands. Normally, the cells of the immune system are ready to spot and destroy anything foreign that could cause the body harm. Immune cells called antigen-presenting cells, which include macrophages and dendritic cells, latch onto pathogens and engulf them, literally swallowing them up. Pieces of the pathogen called antigens are then presented on a major histocompatibility complex, class II molecule, or MHC class II molecule, which is like a serving platter for antigens. An antigen-presenting cell then searches for a T cell that can bind to the antigen. Once found, binding to the antigen helps activate this T cell, and then releases pro-inflammatory cytokines, or signaling molecules that recruit more immune cells, ultimately leading to inflammation. The exact cause for Sjogren's syndrome is unknown, but it seems to be related to both genetic and environmental factors. Genetic factors include genes which code for specific types of MHC class II molecules, called human leukocyte antigen or HLA genes. Specifically HLA-DRW52, HLA-DQA1, or HLA-DQB1. Environmental factors include an infection of exocrine glands like the salivary and lacrimal glands. Infections can damage the cells of the salivary gland and expose their cell components, including their DNA, RNA, and histones, to circulating immune cells. These cell components get picked up by antigen-presenting cells and presented to T cells. In individuals with Sjogren's syndrome, a T cell gets inappropriately activated by these nuclear components and considers them to be foreign nuclear antigens. The T cells then activate B cells, which start producing anti-nuclear antibodies, or ANAs, which are antibodies against the nuclear antigens. Two types of ANAs formed in Sjogren's syndrome are anti-SSA and anti-SSB antibodies, which are formed against the ribonucleoproteins SSA and SSB. Then both T cells and antibodies enter the circulation and reach the exocrine glands, where the T cells secrete cytokines to recruit more immune cells and promote inflammation of the exocrine gland tissue. The cytokines also activate fibroblasts in the tissue, which then produce fibrous tissue that replaces the damaged tissue. The end result is a loss of secretory cells in the glands. Sjogren's syndrome can be primary and happen alone, and in that situation it's called Sicca syndrome. Alternatively, it can be secondary, which is when it happens along with other autoimmune diseases like rheumatoid arthritis. Symptoms of Sjogren's syndrome usually present in middle-aged women and are due to dryness of various body surfaces, When the lacrimal gland is involved, it leads to keratoconjunctivitis, which is the inflammation and ulceration of the cornea and conjunctiva. This causes dryness of the eyes, leading to blurring of vision, itching, redness, and burning of the eyes. When the salivary glands are involved, it leads to xerostomia, or dryness of the mouth, as well as difficulty tasting and swallowing, and cracks and fissures in the mouth. In the nose and respiratory passages, it causes ulceration and perforation of the nasal septum, and can lead to crusting and bleeding. When it affects the larynx, it can lead to difficulty speaking. In some people, there might also be dryness of the skin and vagina. There's also swelling of the glands, which can compress nearby structures like nerves and cause pain. Finally, the dryness of epithelial linings can also make infections more likely. Diagnosis of Sjogren's syndrome is based on a decrease in exocrine gland secretion. For example, sialometry can be done to measure the saliva flow. Blood tests often show the presence of anti-SSA and anti-SSB antibodies. A confirmatory test is a lip biopsy to examine the minor salivary glands, especially CD4 positive T cells, plasma cells, and macrophages, and thickening of the inner duct wall. Treatment of Sjogren's syndrome typically involves medications to suppress the immune response, like corticosteroids, and also medications that increase the exocrine secretions like pilocarpine. Alright, as a quick recap. Sjogren's syndrome is caused by autoimmune destruction of the exocrine glands, most commonly the salivary and lacrimal glands, often following an infection. Anti-nuclear antibodies, typically anti-SSA and anti-SSB antibodies, cause destruction of the secretory cells in the exocrine glands, resulting in dry eyes and mouth.